Good day, everyone. I will be discussing the different carbohydrate disorders. So basically, these disorders have something to do with any impaired metabolism of your carbohydrates. Now, the first disorder that we will be tackling is hyperglycemia. Okay, so from the term itself, hyper meaning there is an increased level of what metabolite glycemia, glucose. So hyperglycemia refers to an increase in plasma glucose levels. So normally the findings in hyperglycemia are as follows. So we have increased glucose in the plasma and urine. Remember, your kidney has a normal renal threshold of 160 to 180 milligrams per dl of glucose. And anything above that would actually cause increased excretion of your glucose in the urine. And so giving us an increased levels of glucose reagent strip result. Now, hyperglycemia is also associated with increased specific gravity in urine. So again, remember, specific gravity are usually affected by the different solutes present in the urine. And one of these solutes that could actually increase the level of specific gravity in the urine is your glucose. And so when there is increased renal excretion of glucose, that would actually mean more solutes found, additional solutes found in the urine, eventually leading to an increased specific gravity. Now, another important laboratory finding associated with hyperglycemia is increased serum and urine osmolality. Okay, so again, in measuring your osmolality, usually we measure the different solutes found maybe in the serum or maybe in the urine. So higher level of your glucose would actually contribute to the urine or serum osmolality, giving us an increased results of the osmolality in both. Now, hyperglycemia may be associated also with increased ketones in the serum and urine. So usually what happens in hyperglycemia is that there is a metabolic defect, or impaired usage or impaired consumption of your glucose, such that your cells now would not keep up, will not actually consume the increased level of glucose that is present in the circulation. Now, since the cells could not actually consume this glucose, maybe, for example, in patients with impaired insulin usage, what happens is that your body needs to find another source of energy. So, in levels wherein there is increased ketones, what happens is that your body tends to metabolize your lipid stores or fats, eventually leading to production of more ketones. That's why they're in hyperglycemia or in any states where there is impaired metabolism of your glucose, it may be associated with an increased ketone level in the serum and in the urine. Now, hyperglycemia may also be associated with acidosis, or it may be also associated with electrolyte imbalance. Now, another disorder that is associated with carbohydrates are very common. We have diabetes mellitus. So this actually refers to a group of metabolic diseases characterized by hyperglycemia. So again, in diabetes, there is actually also increased levels of your blood glucose. So these increased levels of your blood glucose basically results from the defect in the insulin secretion, insulin action, or both. Okay, let me explain that um, clearly. So what you need to remember is that in diabetes mellitus, there is actually impaired metabolism of your sugar or glucose due to a defect in the insulin secretion or insulin action or both. Now, a defect, no? Defect insulin secretion basically arises from the beta cells, no? The beta cells of your pancreas. So what happens is that when these beta cells would not actually produce enough amount of insulin, what happens is that your cells now will not be able to consume or to use the glucose for energy. Now remember, your cells would actually need insulin for it to be able to uptake the glucose and use it as a source of energy. So what happens is that there is impaired or decreased secretion of this insulin. No? What happens is that this glucose now will not be available for energy consumption or cell usage. Okay, so another defect here is when insulin no may be okay in amount or normal in amount. However, the insulin has impaired action. Okay, so by action, we may mean number one, there is mutation. Okay, of these particular hormone produced, such that mutation on the receptors of these hormones, no, such that your insulin now could not actually bind to the receptors in the cells, and so causing these sugars now not being able, no, the cells now not being able to uptake or use the glucose for energy consumption. Now your diabetes has actually two types. It may be type 1 or it may be type 2. Okay, so let's differentiate the two. So type 2 diabetes mellitus is formerly, okay, this was actually the nomenclature before, formerly known as non-insulin dependent diabetes mellitus. Why? Because these diabetes actually may arise, no, from usually arises from a from a defect other than insulin. Okay, insulin action. That's why it's called non-insulin dependent diabetes mellitus. However, a more recent nomenclature would not actually allow, no, the use of this old name because there are actually instances wherein the type 2 diabetes may be insulin dependent. Now, another name, no, it may be adult type or maturity onset diabetes mellitus because before they thought that adult patients, no, only adult patients have type 2 diabetes mellitus. But recently, they have discovered that we actually have patients, no, who are young who may suffer from type 2 diabetes mellitus. So this is known as stable diabetes, okay? Ketosis resistant diabetes and receptor deficient diabetes mellitus. So there's actually no defect. There's actually no decrease in the amount of insulin produced in your beta cells. What's wrong in your type 2 diabetes are actually the receptors, no? A defective or mutated receptors such that your insulin now could not bind to these defective receptors, causing the sugars not being able to be consumed by your cells now, thus accumulating in the circulation, giving rise to increased glucose levels or hyperglycemia as seen in your type 2 diabetes mellitus. So what basically happens is that any risk factors contributing to increased adipokine production, increased free fatty acid production, and inflammatory process would actually result to insulin resistance. So your cells actually become now resistant to the actions of your insulin. So what happens is that your pancreatic islet cells, okay, so normally the insulin could bind to the receptors found in the islet cells, beta cells in the pancreas, such that when it binds now to the beta cells, what happens is that it's now able to consume or take up glucose and be metabolized and metabolize it as a source for energy. However, in insulin resistance, what happens is that your B cells now actually have defective or mutated receptors for insulin such that they become now resistant to the effects of insulin. Now, as a compensation, there it causes now increased production, no? Increased production of your B cells. Okay, so increased number of your B cells or increase the size of your B cells, eventually leading to impaired glucose tolerance. Now, if your B cells in the long term could not actually keep up the compensation, what's likely to happen is that your B cells now dies, okay? So there is decreased number of B cells now, eventually leading to diabetes mellitus. Now, your type 2 diabetes mellitus is characterized by hyperglycemia and relative insulin deficiency. So there are actually many risk factors for your um, type 2 diabetes. No? Risk factors include number one, no, a very important risk factor for type 2 diabetes is your genetic risk factor, such that if you have parents or if you have relatives who are diabetic, you're actually more at risk of developing diabetes mellitus type 2 in the future. Okay? Now, another risk factor are the different environmental factors. Okay? Environmental factors. So what are these environmental factors? So, this would actually include lifestyle factors, no? Lifestyle, lifestyle of an individual. So you might have poor lifestyle, no, with increased intake of glucose levels, a less sedentary or a less active lifestyle. Okay, so as students, you are actually sedentary. No, if you are sedentary because you just want to sit there and study and not taking into consideration the different disorders that you might get from being sedentary. So these are actually environmental factors for the development of diabetes mellitus. Okay. Now, we also eventually know these factors would actually contribute to the development of your type 2 diabetes mellitus, and eventually leading to the different macrovascular and microvascular complications of your diabetes. So macrovascular complications would include coronary artery disease, peripheral arterial disease, and stroke. And your microvascular complications would include diabetic nephropathy, neuropathy, and retinopathy. So usually your type 2 diabetes mellitus has milder symptoms as compared to your type 1 diabetes mellitus. Your type 1 is actually characterized by a deficiency, no, of your insulin. In type 2, you actually have enough number of insulin. However, your cells are actually resistant to the effects of your insulin. So this is a table comparing type 1 and type 2 diabetes mellitus. So notice that your type 1 diabetes mellitus would actually arise from destruction of your beta cells, okay, leading to a decreased levels of your insulin. Now, your type 2 diabetes mellitus, you actually have, as I've said, normal levels of your insulin. However, your cells are actually resistant to the effects of your insulin, probably due to a defect or mutation in insulin receptors. So of the two, type 2 diabetes mellitus is more common with a prevalence rate of 90 to 95%. And I mentioned already that the onset, no, is actually irrespective of age. It may occur at any age for both. Now, the risk factors are as follows. We have usually type 1 is genetic. So most cases actually occur at childhood, whereas your type 2 diabetes mellitus are actually fact these factors are actually multifactorial. Okay, multifactorial. So maybe lifestyle factors such as having sedentary lifestyle or being obese, okay, or some genetic factors and any other conditions such as PCOS, dyslipidemia, and hypertension. So um, in measuring, when we measure the peptide levels, usually there's detectable levels in type 2 diabetes, whereas it's decreased in type 1. And since your type 1 diabetes mellitus is an autoimmune disease, no, there is a presence of your autoantibodies. So these autoantibodies are actually directed to the B cells in your pancreatic islet cells, no, causing it to be destroyed now by these autoantibodies, thus causing B cell destruction, okay, leading to decrease or deficiency in your insulin. Now, ketosis is more common in type 1 diabetes mellitus. Okay, and the usual treatment for type 1 is administration of your insulin. However, for type 2, we can also we also there are actually cases no, wherein we administer insulin subcutaneously. Now, there are other specific types of diabetes. Okay, this may arise due to pancreatic disorders or any other endocrine disorders, or it may be, on the other hand, induced by different medications or chemicals, okay, such as nilantin, thiazides, and glucocorticoids. Now, it may be also caused by any genetic syndromes or conditions and some exocrine disorders. We also have this condition we call gestational diabetes mellitus. So from the term itself, no, gestational. So this basically happens during pregnancy. Okay. So this is similar in etiology to type 2 diabetes mellitus, but how does it differ to type 2 diabetes mellitus? So usually in pregnancy, if you detect an increased level of your glucose in OGTT testing or FBS or HbA1c testing at 20 week, no, more than 20 weeks age of gestation, that is actually considered gestational diabetes mellitus. But if you are able to detect abnormal levels of your glucose less than 20 weeks, no, less than 20 weeks, so most likely the patient had type 2 diabetes mellitus even before pregnancy. No, we call it overt diabetes. Okay, so in GDM, there is actually impaired ability to metabolize carbohydrates, no, as caused by a deficiency of insulin or any metabolic or hormonal changes. And usually in the clinical setting, we check for GDM. We assess for GDM at 24 to 28 weeks of gestation via OGTT, the oral glucose tolerance test determination. So how do we do it? So there is a need, no, to prepare the patient for an overnight fast of 10 to 16 hours. We also allow the patient to consume at least the minimum daily requirements of carbohydrates and exercise normally 3 days prior to testing. The patient also prior should not have smoked or have taken any medications on the day of the testing, and only non-caloric water, no, is allowed during the testing period. So fasting for 10 to 16 hours. So an OGTT result, no, normally are as follows. So we have FBS of 95, 180, 155, and 140 at these intervals. Now, anything more than these intervals may be indicative of gestational diabetes mellitus. Now, if a patient is diagnosed to have gestational diabetes mellitus, okay, so we reassess the patient postpartum or after giving birth. Now, the recommended time period for assessment would be from 6 to 12 weeks postpartum, no, after delivering the child. Now, to detect GDM for high-risk patients, high risk would actually mean those patients who have risk factors for GDM, okay? We may opt to do a one-step 2-hour OGTT using 75-gram load. For patients who are low risk or average risk, we may opt to do the two-step. No? So first we give 50 grams in the first hour, and on the third hour, we administer another 100 gram of your glucose load. Okay. Now, usually, the if we analyze glucose in the laboratory, the recommended temperature is at room temperature of 20 to 25 degrees centigrade. Now, any delay, any delay in the analysis of glucose specimens. So I'm actually talking about glucose determination in general, no? Not just in OGTT determination. So any delay would actually cause a decrease in 7 milligrams per DL per hour from the original level, no, contained in the patient sample. Now, if you refrigerate the sample at 4 degrees centigrade, so from 7, you now have a much lesser, lesser decrease in the value of your glucose in the sample. Now, we must take note also that we analyze specimens which are not contaminated with WBCs and RBC. That's why the most preferred specimen for glucose determination is your serum specimen, devoid of any cellular elements. Why? It's because these cellular elements would actually metabolize or use glucose, okay, giving us a false decrease results. Now, in serum specimens without bacterial contamination or leukocytosis, results may remain acceptable even after a delay of 90 minutes, no, before separation of serum and the cells. Okay, why? It's because, again, cells, cellular elements would actually use up glucose, no, would metabolize glucose, giving us a false decrease results. Now, samples for glucose measurements are as follows. So we have this what we call random blood sugar, okay? So random blood sugar would actually mean we take the glucose at any time, okay? So random blood sugar is usually taken using capillary blood samples. Then we also have this what we call fasting blood sugar, wherein we let the patient pass for 6 to 8 hours, no, before we collect the specimen. Now we also have 2-hour postprandial, okay, blood sugar. So we let the patient eat a meal, and 2 hours after we get the glucose levels. We test for the glucose levels. Now, another another sample that we may get is actually glucose tolerance sample, no? So usually we collect multiple blood sugar samples, and this would actually help us determine how well the body metabolizes glucose over a required period of time. Okay, so this is recommended, no, for patients who have been suspected with gestational diabetes mellitus. Okay, so fasting glucose in whole blood is 15% lower in serum or plasma. Why? Remember, your whole blood contains cellular elements, and these cellular elements are able to metabolize glucose, thus giving us a lower glucose levels. Now, the standard clinical specimen is a venous, okay, plasma glucose Serum, okay, is appropriate for glucose analysis only if it is separated from the cellular elements within 30 minutes, no, of collection. And venous blood glucose is usually 7 milligrams per dl lower than your capillary blood specimens. So with prolonged storage, okay, fasting blood glucose will decrease 2 milligrams per dl per decade. Postprandial glucose would decrease 4 milligrams per dl per decade, whereas your OGTT um, specimens would decrease 8 to 13 milligrams per dl per decade. Now, we have this what we call, no, other types of or methods in determining OGTT specimens, in processing OGTT specimens. So we have is what we call Johnny Isaacson method. So single dose method wherein we allow the patient to take in, no, take in a glucose load at one time, and then we determine the glucose level at each particular period of time, no, from 30 minutes or fasting, 30 minutes to 1 hour, second hour to 2 hour postprandial, post taking the glucose load. Now, we have this what we call Exton or Rose method, wherein we let the patient take in divided doses of glucose load. Okay? So, added plasma glucose after the intake of glucose load would be from 30 minutes 30 to 60 milligrams per dl amount fasting. 1 hour would be 20 to 50. In the second hour, 5 to 15. And after 3 hours, it goes back to fasting level or below it. Now, we also have another way, no, of determining glucose test. Okay, glucose tolerance test via injection IV, no, administration intravenously of your glucose load. So this is usually indicated for patients with gastrointestinal disorders, wherein 0.5 gram of glucose per kilogram body weight is administered intravenously, and the patient also is required to fast. Okay, so the blood collection is after 5 minutes of blood glucose administration. So indications for IV intravenous glucose tolerance tests are for those patients who are unable to tolerate large carbohydrate load, and for patients with altered gastric physiology, or for patients who had undergone previous operation or surgery in the intestine, or for patients with chronic malabsorption syndrome. So these are the criteria now, okay, for fasting glucose. So a pre-diabetic level would be less than 100. A level of 100 to 125 milligrams per dl is considered an impaired plasma glucose. Okay, so diabetes would be more than or equal to 126 milligrams per dl. So usually for patients with impaired plasma glucose, okay, so what we do here is just we treat the patient, we advise the patient for lifestyle modifications. Whereas for patients with more than or equal to 126, no, we advise the patient to start taking oral medications. Okay. Now, the same goes with oral glucose tolerance test. A level of 200 or more milligrams per dl is indicative of diabetes mellitus. Now, diagnostic criteria for diabetes mellitus would be as follows, no? So, when using random blood sugar, the level must be 200 or more, no, milligrams per dl with symptoms such as polyuria, polyphagia, and polydipsia. No, again for FPS 126 or more, and for OGTT 200 milligrams or more. So impaired fasting glucose usually is characterized by an FBS level of 100 to 125. So again, I mentioned that in clinical setting, no, if we have patients who have impaired fasting glucose, we usually manage this. We advise the patient for lifestyle modifications. We tell the patient to exercise, to do away with sedentary lifestyle, and we also tell the patient to maintain a low carbohydrate, low fat diet. Okay. The same goes with patients with impaired glucose tolerance test. Now, another test that we use in the laboratory to monitor, to determine long-term control of glucose is your glycosylated hemoglobin. Okay, so this usually reflects the average blood glucose level over the previous 2 to 4 months and usually performed every 3 to 6 months in patients with diabetes. Usually in patients with diabetes, the usual cutoff is an HbA1c level of more than more than 6 to 6.5. Okay, so a level above those are actually considered as diabetes already. So here I mentioned this. Okay, so a level of 6.5 above is considered diabetes mellitus. Now, the usual specimen that we use is a whole blood anticoagulated with EDTA, and we do not let the patient fast, no, because this is actually not affected by the dietary status of the patient on that day. So these are the conditions, no, wherein there are false results contributing to false results of your HbA1c level determination. So in patients with iron deficiency anemia or in patients with shortened RBC lifespan such as in hemolytic anemias, okay? So or in also in patients with hemoglobinopathies or patients who have opiate or alcohol intake or in patients who are having no lead poisoning and salicylate poisoning. Now another carbohydrate disorder is hypoglycemia. So this is actually opposite, no, to hyperglycemia and diabetes mellitus. Why? In hypoglycemia, there is actually a low serum level, no, below 70 milligrams per dl, such that usually your body's first line, no, in states wherein there is a decreased level of your glucose, particularly at 65 to 70, is to release your glucagon. So what's the action of your glucagon? So glucagon is released from your alpha cells, alpha pancreatic cells, and its action is to actually induce, no, gluconeogenesis or glucose formation or glucose production. Now, if patients continues to have decreased glucose levels such that it reaches now 50 to 55 milligrams per dl, so you would actually observe now symptoms of the patient, okay? And levels below 50 is actually detrimental to the brain of the patient. So the symptoms of hypoglycemia are divided into two, no? Could be neurogenic or neuroglycopenic. So neurogenic symptoms involve palpitations, anxiety, diaphoresis, hunger, and paresthesias. And neuroglycopenic symptoms involve dizziness, no, tingling sensation, and among others. Now, what I want to point out is that the diagnostic criteria for hypoglycemia should fulfill this what we call people's triad. Okay, so 3 criteria for us to say that the patient has hypoglycemia. What are these? Symptoms consistent with hypoglycemia. The patient must have either neurogenic or neuroglycopenic symptoms associated with hypoglycemia. And on CBG determination, okay, on glucose determination, particularly we just use capillary blood. No? So in glucose determination, there is a level, no, below 70. And upon administration intravenously of glucose level, of intravenously of any glucose forms, there would be noted disappearance or relief of the symptoms, okay? Thus fulfilling the Whipple's triad. Now, another carbohydrate disorders are this what we call glycogen storage diseases. Okay, Now, before we proceed, before we discuss the different glycogen storage diseases, allow me first to review. Okay, let's review first how glucose is metabolized and how glycogen is formed. So usually your glucose, okay, your glucose would actually not in use, nor glucose stores would, would actually result to formation of your glycogen. Now, your glycogen, okay, in the muscles is actually metabolized by the enzyme phosphorylases, phosphorylases, and eventually also metabolized by a debranching enzyme leading to formation of your glucose 1 phosphate. Okay, your glucose 1 phosphate is actually the form of glucose which may be used by your cells to form ATP as a source of energy. Now, when not in use, your glucose 1 phosphate may be converted into UDP glucose and by another branching enzyme to form glycogen. Now, your glucose 1 phosphate, okay, is converted to glucose 6 phosphate, and this glucose 6 phosphate, okay, by a phosphatase transporter may be converted into glucose in the liver or in the muscles. During anaerobic states, the glucose 6 phosphate may be converted into pyruvate, eventually leading to formation of your lactate. Now, any deficiency, any mutation of the enzymes involved in glycogen and glucose metabolism would actually lead to this what we call glycogen storage diseases. And we have a lot, okay? So we have hepatic and muscular glycogenosis. So under hepatic, we have these conditions. So for examination purposes, you need to memorize the enzymes, enzymes and the affected organ and the different type also. And for your muscular type, muscular glycogenosis, these are as follows. Okay, with the different, you need to familiarize also yourself with the different clinical features. Okay, so that ends my lecture for carbohydrate disorders. Thank you everyone. Have a good day.